This recording is meant to review with you some of the common terms you'll hear and need to know when we talk about pulmonary disease in class. Many of these terms you've been exposed to in the past, but we want to take a few minutes and review them with you to make sure you're where you need to be for class. So here's a list of all the terms we're going to go through and talk about, but before we do that, let's do a little bit of a pulmonary system review. So if we think about the lungs, we have the trachea, which then goes into the bronchus. Down to the lungs we'll go. We go down from the bronchus to the bronchioles. We get down to the lower part of the lungs. We get down to the alveoli, or the alveolar region of the lungs, and this is where the gas exchange takes place in the lungs. We can think about breaking the lungs up into two different zones. First of all, you have the conducting zone, which would be here to here. This is the part of the lungs that's responsible for getting the air to the respiration zone down here, and this is where the actual gas exchange takes place. So the respiratory zone is where the gas exchange takes place. The conducting zone is where the how we get the air down in that region. The acinus, this is the area as we see from here on up. I'm going to reverse myself actually. The acinus is distal to this part, so it's this area that we see just distal to the terminal bronchiole. That's more the area where the conducting zone is at. The parenchyma would be this area down here. It's more the alveolar region of the lungs themselves. And if we zoom in even further on this picture, the interstitium is that space between the epithelium of the alveolar region and the capillary endothelium. So when you think about this is where the capillaries are at, where that gas exchange taking place. Right in here would be the interstitium, that space in there where the gas molecules have to cross in order for the gas exchange to take place. So those are the different regions of the lungs that we might think about. Here's another crude drawing of the respiratory system, but again, we think about this as the bronchus and the bronchioles, or say the trachea, the bronchus, the bronchioles, and we just fast forwarded down here to the alveolar region. Let's think about the walls of the respiratory system very quickly. We're going to turn the lungs on their side in a sense, and again we think about the trachea, the bronchus up here. If we really zoom in on this area, what we'd find is that the walls are very, very thick. Okay, there's a lot of smooth muscle in there. There's a lot of pressure because think about all the air molecules are coming down here, and all that air is traveling maybe through one or two tubes in our pulmonary system at that point. We're not diffusing the air over a large volume quite yet, so those walls have to be very strong. And it doesn't really matter if the walls are thick from the gas exchange zone because there's no gas exchange going on in that area there. So we also, if you remember from physiology, we have little cilia in the walls themselves, and they help protect the airway, move foreign bodies up and out of the lungs. Now if we zoom into the alveolar range and just one singular alveolus, the wall is very, very thin because, as I said in that last slide, those vessels are coming through, those capillaries are coming through, and they're all intertwined. We think all the different air sacs there might be in there, and those vessels are all intertwined in there to provide a high cross-sectional area but a low diffusion distance to allow the gas exchange to take place. So just remember the differences that we might see in the walls themselves. So I just mentioned the alveoli. Again, these are the small sacs we have in our lungs where the gas exchange takes place. Very thin wall. There's surfactant that decreases some of the surface tension to help keep those airways open. If we go zoom in really close on these, there are little connectors between these air sacs called the pores of Kohn, which allow gas to go back and forth in between these. This is particularly effective when someone might have damage to the lungs, so the airways that lead into here, maybe this one's damaged. It still allows those air molecules to come in this way and into this alveolus to allow that gas exchange to take place, and then the air to come back out that way to provide proper exchange of oxygen and carbon dioxide. So we see that's your alveolus or your alveolar region. The pleura, this is that membrane that lines the thoracic cavity. You see there's three different types. There's the parietal pleura, visceral pleura, and then there's that space between those. So if you think about this being the lungs, that being the chest wall, there's pleura that lines the lungs themselves, and there's that pleura that lines the chest wall. And if you think about two pieces of glass and you put a little drop of water in between them, they stick together, right? Remember what we did back in biology when we looked at slides and did in science class? That allows those to stick together, allows them to slide, allows them sliding to take place very easily between the chest wall and the lungs, but also holds them together to keep the lungs open. And then there's that space in between the pleura called the pleural cavity, and we'll talk a little bit later about the fluid that is in that region here. So let's go back and talk about pressures in and around the lungs, and we think about that pressure in and around the lungs, and we're just going to think about a very basic lung. We have atmospheric pressure up here, and this is the air that we breathe in and out, that we're bringing in through our mouth. This is the intrapulmonary pressure, I should say. And then we have the chest wall. Remember, the chest wall is kind of coming along here, kind of around the outside of the lungs. And here you have the pleural pressure. But then also remember you have the atmospheric pressure out here. So there's a balance of all these pressures that allow us to breathe. So when we bring air in, remember that the pressure in the pulmonary goes down. There's that pressure difference, so air flows in. And then when we breathe out, the pressure in the pulmonary is greater and the air flows out. Mediastinum, just a term to be familiar with. That is that if we think about the area of our lungs and our chest wall, it's about right behind the upper part of our sternum, and that's where we have our heart and our nerves and blood vessels. It's a large area that you'll see, or an area your chest wall right in here, and you'll read medical reports and doctor notes that talk about this, or surgical procedures that talk about the mediastinum. Just important that you know what they're referring to. A pneumothorax. So this is when air gets into that pleura space. So this drawing, we have our lung in here, and then we have our lung right in here, and we have our pleura space right there. What can happen? There can be some sort of protrusion of the chest wall, so a breaking of the chest wall, or something gets stabbed into the chest wall. What's going to happen is air is going to rush into that pleura space, and what that's going to actually happen is the pressure is going to increase in the pleura space greater than the pressure in the lungs. So there's an inward pressure into the lungs themselves. Okay, so because there's that pressure difference, the air rushes into that pleura space, and the pressure becomes greater in the pleura than in the lungs. And then how do we treat that? Well, so we have that damage to the chest wall, so that can be patched or sewn, or however they can do to patch up that hole so we're not seeing that air coming in. So you have to fix that issue. And then actually a chest tube can be put in. So there can be some sort of chest tube. A needle could be put in to help drain the air out of the pleura space. Something should be done to reestablish that pressure balance in the chest wall. Pleural effusion is the same concept. So again, we have the lung, and now instead of air coming in, there's some sort of fluid that comes in. So that space fills up with fluid, and the fluid causes pressure into the lung, and then a collapse of the lungs is what we might experience with a pleural effusion. A hemothorax, again, the same kind of theory, except it's being filled with blood. Treatment's the same way as a pleural effusion, using a chest tube to drain some of that fluid out of that pleura space. We have empyema. This is a collection of pus in the space, so don't confuse with emphysema. It's not emphysema misspelled, it's empyema. The fluid in there becomes infected, the pleural fluid becomes infected, we get pus that filled up, antibiotics to treat the infection, but also the chest tube, like we showed you before, to drain that out. Consolidation of the lungs. With consolidation, what we're seeing is the alveolar space is filled up somehow, and you see this on this chest x-ray. So you can look at that and you can see that there's this white mass, this white area in here that shouldn't be there in a chest radiograph. Secretions filled up in there, fluid, cells, tissue, whatever. And think about how that's going to affect breathing, the comfort of breathing, the ability to get rid of carbon dioxide and pick up oxygen for our blood cells. Infiltrates. With infiltrates, you see these spots, kind of these spots that you might see all throughout the lungs. This, again, is something happening inside the lungs themselves, so pneumonia, edema, something along that lines is what you might see there. Atelectasis, this is a collapse of the lungs. Now, the blockage can be in the lungs themselves, or it could be in the pleural space, and that's where it comes into treatments. And this is an important thing to make this differential diagnosis on, not because you're going to be actually treating the atelectasis, but if you're going to be knowledgeable and help support and manage it, you need to know different. So if the infection or if the issue is in the pleural space, right, this is our lungs, if there's something in the pleural space that's causing that collapse of the lungs, that atelectasis in that area, how are you going to treat this? Well, they're going to put a chest tube in, right? Drain that stuff out, get the air out, which will establish that balance of pressures. What can also happen, though, is there can be secretions that build up. So because of infections, there might be stuff in the lungs which then causes that atelectasis to take place. So you could put a chest tube in, right? But that's not really addressing the issue. You're not going to see any change. What really needs to happen is we think about this lung being connected to the airway, of course. We need to do something to cause those secretions to come up and out. So some of those techniques we might use in physical therapy, for airway clearance techniques, medications to loosen them up, those are the big ways to get rid of those secretions that you might have in the chest wall. So the chest x-ray is going to look like this, where you see the kind of this white issue in here. That's that atelectasis, pretty clear from this slide. Obstruction, this is that difference I talked about before on the last slide. So it could be, you know, the lungs themselves, there's a blockage right here, secretions build up, whatever. Eventually, you know, all the air, the blood vessels are coming around the different parts of the airways. Eventually, all the air molecules are going to be taken out, and this is going to eventually collapse, causing the atelectasis. Versus the compression, like we said before, you have the airway like this. There's something in here causing that pressure, the collapse of the airways, so more of a compressive atelectasis. So just to make this distinction, the pneumothorax, pleural effusion, and hemothorax, emphysema, these are outside the lungs in the pleural space. So make that distinction there. Consolidation, infiltrates are inside the lungs, so secretion is building up, those sort of things, infections, and the atelectasis can be inside or outside the lungs. A bolus or a bullae or bully, depending on who you hear say it. What happens here is that we have all of our alveoli, which are down in here. We normally have sitting like this. What might happen in this situation, actually, is we have the same thing here, but what happens is these break down in the walls. Instead of having multiple small ones, we now have fewer bigger ones. And as we know from studying the Fick's laws of diffusion, that's not a good thing, right? Because it takes longer for those air molecules. They have further distance to travel, as opposed to here, there's less distance for those air molecules to travel. So the better situation, obviously, is having more alveoli, smaller, bigger cross-sectional areas. So this is not a good situation. It compromises breathing and good, healthy gas exchange. And you'll see some examples here on the chest radiograph. So you see some of those things in the chest radiograph. Kind of hard to maybe differentiate between infiltrates and this, but of course that's not our job to make that distinction on a chest radiograph, but just understanding the differences and what that might involve. Aspiration. You will see aspiration if you work with older adults, patients who've had strokes, brain injuries, patients with cognitive issues where they're not able to pay attention to their eating. Something enters the lung. It can be food, vomit, secretions, as you see. Over time, that can lead to pneumonia. As we know, our lungs are a great breeding ground for germs. We put some foreign body in there, again, food, vomit, secretions, anything like that. It's going to lead to pneumonia eventually. And there's all sorts of initiatives in hospitals to prevent this, all sorts of guidelines we might follow to ensure our patients don't have aspiration, and if they have certain swallowing precautions, we try to be aware of that to prevent aspiration from happening. In some situations, the best way to treat lung disease would be to take part of the lungs, and we think about upper, maybe a middle, and a lower part of the lungs, go in and actually remove part of the lobe. It could be an area that has a lot of bullii in it or bulbi in it, and by taking that out, we give more room for the rest of the lungs to function. You make room to allow good expansion of the rest of the lungs. In a sense, taking out some of that dead space to allow for better gas exchange. Lymphadenopathy, this is where the lymph nodes are abnormal in size. You might see this in a certain area. This can be a variety of different things going on, but definitely needs some further evaluation by a physician, medical team to determine what's going on with the lymphatic system. So at this point, you probably want to go off and take your quiz on Blackboard to make sure you know these terms. Best of luck to you.